So liver is a very important metabolically key organ. It governs the metabolism. And what's interesting is the lot of macronutrients which come to liver is controlled by a lot of hormonal inputs and also by neuronal inputs. And all of them put together do the function of liver, because liver acts as a hub, a metabolically active hub, connecting metabolically to the adipose tissue and to the muscle tissue. So that's why it's a very important organ. And any derangement in either excess nutrients or the signaling mechanism results into a fatty liver disease. So that's how the beginning of fatty liver. And it's so important, that's why we have the June 12 is observed as the International NASH Day. And it is to join the awareness about non-alcoholic steatohepatitis and a fatty liver disease. So with that introduction, NASH, the word was coined by Jürgen Ludwig in 1980. It's the most common liver disorder in industrialist countries. It actually means that the liver has more than 5% of the fat, and type 2 diabetes, obesity, dyslipidemia, and a cardiovascular disease being the most frequently evaluated and cited as risk factors for the non-alcoholic fatty liver disease. And the prevalence is anything from 5.5 to 31%. It is 3 to 10 times more prevalent than Hep C. You can imagine the impact of the non-alcoholic fatty liver disease. And if you look at the epidemiology globally, it's about 25 to 24%, and it varies from countries to country. If you look at Asian countries, it's something about 27 to 37% is the incidence of the non-alcoholic fatty liver disease that you see here. So liver is a central part of the metabolic syndrome. This is yin-yang, the metabolism and inflammation, and therefore it's very important because diabetes, obesity, cardiovascular disease, and dyslipidemia is all controlled to a large extent by liver. And metabolism inflammation and insulin resistance is a link between these two manifestations. So let's come back to the physiology, and we'll start my talk now of pathophysiology of the non-alcoholic fatty liver disease. Now this is how you see in a fed state. As soon as you eat food, the glucose comes inside, that stimulates the release of insulin. And insulin takes the glucose into various sensitive cells. For example, the fat, the adipocytes, are dependent on insulin action. There are insulin receptors on the adipocyte, and therefore the glucose is trafficked inside to produce glycerol in the fat cells. The liver also picks up the glucose, and under the influence of insulin, there's a glucokinase activation, and therefore it can either convert into a glycogen or can convert into lipids, or the glucose goes into muscle. So this is how this is disposed of in these various areas. In a fasting state, what happens is there's no insulin. So the glucagon kicks in, and glucagon produces glucose from the liver, and that glucose is utilized by all the tissues, especially the fat and the muscles. And therefore, what happens is, in the fed state, there's an increased glycogen production, there's a decreased gluconeogenesis, and there's a de novo lipogenesis occurs. And there's also glucose which goes into the muscles and stored as a glycogen, and also glucose is used for the metabolic process in the liver. In the fasting state, what happens is there is a decreased glycogenolysis, increased glycogenolysis, there's an increased gluconeogenesis and decreased lipogenesis that occurs in a normal situation. And the fat brings about lipolysis because there's an enzyme called hormone-sensitive lipase, which is normally inhibited by insulin. And with less of insulin, the hormone-sensitive lipase is no more inhibited, the lipolysis occurs, and this lipolysis is a source of energy during the phase of fasting or when you're not eating food. Now let's turn to what happens in diabetes pathophysiology. Now what happens here is these patients have insulin resistance, and you can see there's a fat accumulation in the organs, especially the liver and in the muscles. So muscle has got a lot of fat, and because of that, there is a resistance to insulin action. And therefore, when you eat food, what happens here, the glucose which comes up cannot be taken up by the fat because there is insulin resistance, and it cannot be taken up by the muscles because there is again resistance to the muscles, glucose. So all the glucose is trafficked into the liver. And in the liver, there is a decreased glycogen synthesis, increased gluconeogenesis because of insulin resistance, because the insulin is supposed to act on the liver, especially on the glucokinase enzyme. The glucose can walk into the liver because there are GLUT2 transporters. There are two-way transporters to take the glucose into the liver. So there is a GLUT2 transport. Liver has the glucose content. So therefore, there is decreased glycogen content, increased gluconeogenesis, but the fat synthesis continues. And of course, the food can't enter the liver because there is a sort of insulin resistance. And the same thing happens in patients who are in a fasting stage because there is no insulin, there is more glucagon. And whenever the glucose does not enter the cell, it gives a signal to the brain that we are not getting food because the glucose doesn't enter the cell. So the brain brings about production of counter-regulatory hormones like epinephrine, norepinephrine, glucagon, growth hormone, cortisol, and that brings about acute insulin resistance. Therefore, more glucose comes up in circulation. That's a very paradox that there's so much glucose outside the cell and very less glucose inside the cell. So this is exactly what happens in patients who have diabetes, the pathophysiology of diabetes. Now, what is important again is to understand what is the insulin resistance which occurs purely in the liver, which is called a hepatic sensitive insulin resistance, versus what is called a general insulin resistance. This is the Michael Brown's from Dallas, a good study on mice. And what he looked at people who are normal mice. As soon as the glucose is produced, glucose is brought to the liver, the stimulation of FOXO protein. FOXO is a very important transcription factor which stays in the cytoplasm, doesn't get into the nucleus. It should not go into nucleus. So therefore, there is a phosphorylation of FOXO protein, and that brings about decreased synthesis of glucose, because therefore gluconeogenesis goes down. But it stimulates the sterol regular element binding protein, and therefore there's increased production of triglycerides. So therefore, whenever a normal person, the action of insulin in the liver is to depress the glucose production or store the glucose as a glycogen, or the still excess glucose comes, convert the glucose into triglycerides. That's the function of a normal liver. But the triglyceride is produced, and these triglycerides acts as a source of energy, and it can be stored in the fat cells and can be stored in the muscles. So this is what is normal person. Now you have a Lurco mouse which has got knockout of the receptors of the insulin on the liver. So that's classically when you have a selective insulin resistance in the liver. What here happens is, as the glucose comes inside, the FOXO is no more phosphorylated, and therefore the inhibitory action on the glucose production goes off, so there's excess glucose production. At the same time, the synthesis of sterol element binding protein continues, so there's excess amount of triglycerides. But unfortunately, there's a resistance of the insulin in the muscle, so the glucose can't enter. So the muscles have entry of triglycerides, and also fat has entry of triglycerides, and furthermore, excess triglycerides enter into islets of liver, islets of pancreas, and therefore has the ectopic fat in the islet of pancreas, and therefore can also produce what is called a lipotoxicity of the islets of Langerhans. So this is classically what is seen in people who have a selective insulin resistance in liver. If you are a general insulin resistor, what happens here is there again reduction of FOXO action, so more glucose, and there is reduction of triglycerides, so they have a less triglycerides and more glucose. So this is the situation where the patient does not have dyslipidemia but has only hyperglycemia. So this is a situation which occurs in a pure insulin resistance. This is a selective insulin resistance of the liver. And this important aspect of selective insulin resistance brings to me the picture of John Dennis McGarry, who said in the editorial, what if Minkowski has been egoistic? What it means if the Minkowski was the first man who tested the urine, not TASTE, but TES, tested, TASTE. And when he tested the urine, he got the sweet smell. Therefore, he diagnosed diabetes as a diabetes mellitus. Suppose he had lost the sensation of taste, he would have smelt acetol. And he would have said, this is not diabetes mellitus, but this is diabetes lipidus. That's how the understanding of pathology, that this could be more of a lipid disorder rather than the glucose disorder. And therefore, this understanding is very important. And this man got the Banting lecture in 2001. But unfortunately, he could not speak because he had neuroblastoma. So he had acute aphasia. And he went for the lecture, Banting lecture, the same lecture. But lecture was given by the then president of ADA, and that was Bob Sherwin. Bob Sherwin gave that entire presentation of the Banting lecture on his behalf because he could not speak. Unfortunately, in 2002, he died. He was born in England, and he was told to be a very prolific teacher of biochemistry. The students were very fond of his lecture because he used to take a lot of time in teaching biochemistry to the students. Now with that, let's come to the further understanding at the cellular level. Now this is the fat, and normally I said that triglycerides are suppressed because of the hormone sensitive lipase. So therefore, in this liver, you have a beta oxidation of the fat. That is the classical function of the mitochondria. And peroxisomes have PPAR alpha, which is supposed to deal with the triglycerides. Okay? And therefore, the VLDL production normally occurs from the liver. This is a normal situation. And sometimes from the glucose and fructose, you get what is called de novo lipid synthesis that can occur. Now, when you have an insulin resistance as the first player that takes place, what happens is the hormone sensitive lipase is no more inhibited. There have a large amount of lipids or the fatty acids walk into the liver. And there's also stimulation of sterol regulator element binding protein. So that brings about de novo synthesis of liver and lipids. So liver is flooded with a lot amount of fat. So the fat is too much in the liver. It is trying to get rid of this fat by activation of peroxisomes and to some extent a beta oxidation that occurs in mitochondria. This tries to do it and therefore tries to produce more triglyceride. That's why we see in patients of diabetes, they have a hypertriglyceridemia. That's because of the flux of so much of fat coming to liver. It ultimately wants to get rid of it by producing more triglycerides. Now furthermore, the next player is a mitochondrial dysfunction. Now as this is flooded with so much of lipids, this mitochondria can't handle this. They can't take up that much load of the lipids coming into the mitochondria. So therefore, they undergo what is called as they produce what is called reactive oxygen species, and that brings about inflammation, fibrosis, and apoptosis, and that is the inflammation setup. So therefore, the inflammation sets in. The next one is what is called as the endoplasmic reticulum distress or a stress. What happens is here, the endoplasmic reticulum is supposed to do the job of folding of proteins. The function of ER is to fold the proteins. When that folding does not occur, so unfolding protein response is what happens, and that stimulates the JNK, Janus kinase activity, and that brings about again inflammation, apoptosis, and impaired signaling. So therefore, the next problem that occurs is the ER stress that occurs because there is so much of nutrient loaded in the liver. Okay, that again now brings about the next topic is the adipose tissue dysfunction, because these adipocytes are so much triglyceride loaded, they become larger in size. And the fat cells become larger in size, that is sensed by the immune cells as the abnormal cells. So the immune cell starts mounting reaction to this. So therefore they produce interleukin-6, TNF-alpha, and leptin. We all know leptin is action on POMC neuron, and by POMC neuron supposed to again bring about satiation, therefore a person starts eating. But most of the patients of obesity have leptin resistance. So leptin doesn't work there, or therefore the patient tends to eat more. And this leptin has also very peculiar action on what are these called as stellate cells. And the stellate cells are located in the space of DC. And the function of stellate cell is not known. It is believed that it stores vitamin A and retinol. Now this stimulation of the stellate cell, because so much of influx of fluid, of the nutrients, and leptin specifically. Leptin is known to stimulate the stellate cells. And when the stellate cells get angry, what it produces fibrosis. So the fibrosis is produced by stimulation of the stellate cells. A very important therapeutic implication is metformin, is one drug which prevents this kind of stimulation of stellate cell and producing fibrosis. Therefore, the metformin has come in a big way. Anup Mishra from India has done a great lot of work on this aspect of metformin therapy in patients of NAFLD, where he's shown that even in the patient with advanced liver disease, metformin can be used to tackle this aspect. Is very important. And lastly is what is called a dysbiosis. Patients with diabetes have the imbalance between the gram-positive and gram-negative bacteria. And when this dysbiosis occurs in the microbiome, which stays inside the colon, you'll be surprised that the colon contains the bacteria, which weighs 1.5 kilograms. So much bacteria are located in the colon. And this is a quite good, well-balanced microbiome between gram-positive and gram-negative. When this balance gets disturbed with either a high-fat diet or by excess calorie intake, you get the excess production of what is called lipopolysaccharides, which is the production by all gram-negative bacteria are known to produce lipopolysaccharides. This is what is called endotoxemia or a metabolic endotoxemia. And this metabolic endotoxemia further brings about further inflammation and further onset of diabetes. One more point I want to highlight here, which is very important to understand, is that when this kind of dysbiosis occurs, it also produces a substance called TMA, trimethylamine. This trimethylamine reaches the liver, and in the liver it gets oxidized to produce TMAO. And this oxidized product of trimethylamine, which is actually a gas, when it gets oxidized, is extremely atherogenic. So one of the causes of atherogenesis is because of dysbiosis, and that brings about the trimethylamine oxidase production, and that's how you get the dysbiosis as a next player, which worsens the problems in patients with diabetes producing dysbiosis. With all this, there is a state of inflammation. So chronic inflammation is different from acute inflammation, and this chronic inflammation brings about stimulation of JNK and NF-kappa B, and that has the metabolic endotoxemia, producing a kind of insulin resistance and again a fatty liver disease. And that's again what you get, the fatty liver disease. So if in short what I said, this is the healthy hepatocyte with few fat globules, and therefore these fat globules enlarge in size, and therefore that is called steatosis, and the nucleus is pushed to the side and you get steatosis production, and once the fibrosis sets in, it's called steatohepatitis. It's said the consumption of coffee can reduce these kinds of inflammation, so therefore those who drink coffee perhaps have the advantage of not getting steatosis and steatohepatitis. And of course we know that the free fatty acids from the adipocytes enter the liver. We know about the alcohol. We know about the fructose containing food. They all can cause the steatohepatitis and NAFLD. So that's about, in short, what is the pathophysiology of NAFLD. So these are risk factors like obesity, impaired fasting glucose. Hispanic heritage has a specific genetic background to get NAFLD. Male gender, there are gender discrimination. Male and female are different, and the entire study of this gender difference is what is called sexosomes. The X and Y chromosomes exist in all the cells of the body, and therefore certain diseases are common in women, or certain drugs people don't respond, especially if it's a female patient. For example, the value study brought this out very carefully. In value study, what happened that people used valsartan, and female patient did not respond to valsartan effectively. Then they realized probably it's the sex difference that is responsible. And therefore, some diseases are very common male, some common very female. That's because the difference of X and Y chromosomes. And remind you that every cell of the body has X and Y chromosomes. And of course, the there's a coined word of hepatic manifestation of metabolic syndrome. So this is actually a metabolic syndrome and the NFLD are the two sides of the same coin. And what happens here is a substance called ferritin B, which is supposed to be, oh, I'm sorry. It gets automatically. So this is called ferritin B, which is actually called cargo protein. It is supposed to transport the protein, especially albumin and everything, and it's been shown that the excess production of ferritin B is supposed to be responsible for NAFLD and diacylglycerol accumulation in the liver, which is the intermediate of the fat product, which is a highly substance which produces the insulin resistance. And there's one more substance called PNLP3. This is a gene polymorphism, and this polymorphism is also supposed to cause accumulation of fat in liver. This is the normal polymorphism. This goes automatically forward. And this is a normal one. So there is a normal lipid which is less than 5%. And those who have got this polymorphism of gene 148 MET is supposed to cause excess amount of hepatocellular fat accumulation, and therefore this is a genetic cause for having the fatty liver disease, and therefore we know that the content of the fat in liver is more than 5%. And therefore, as you see here, that form of the homozygotes have a high risk of developing cancer, NAFLD. One more interesting aspect is about the hepatic FGF, which is produced from the liver. It decides about the taste. Very interesting observation that FGF can also have the negative action on the consumption of alcohol and sweet. Could be this analogs of FGF1 could be a new kind of therapy for patients of NAFLD. Now that brings about to an important aspect. Where there is a hepatogenous diabetes, is it neglected? Is there a special condition which is known as a liver-causing diabetes, hepatogenous diabetes? And this is the presentation. And there is again one more article which talks about hepatogenous diabetes in these patients. And what actually happens in these patients is that the liver is an important organ because it clears 50% of the endogenous liver. It goes automatically forward. It's in auto mode, I guess. So that is very important, that the liver clears 50% of the endogenously produced insulin. The exogenous insulin, the large part is cleared by the kidney. In the endogenous insulin, the only C-peptide is cleared by the kidney, but the large part of insulin is cleared by the liver. And what happens in this patient is, because of the non-cirrhotic chronic liver disease, there is increased amount of cytokines and also sarcopenia, and that brings about insulin resistance. Because of the decreased clearance of insulin by the liver, because the liver disease itself, that excess insulin produces insulin resistance. That's very important because it's a protective action. That's why it protects against developing insulin resistance. That's why these hormones go in the up and down fashion to prevent insulin resistance. If it was continuously produced in the body, you would have produced insulin resistance much earlier. So that's how you get this kind of insulin resistance in this patient. And the hepatotoxicity of the cirrhosis also produces damage to the liver, to the pancreas, and that's how you get a beta cell dysfunction and insulin resistance, and you get impaired glucose tolerance and diabetes. The best example is Hep C virus. Hep C virus can produce diabetes purely because of involvement of the liver. So liver has a very important function on that. So Roy Taylor talked about twin cycle hypothesis in type 2 diabetes. So positive calorie balance, which is there most of the people with patients of pre-existing insulin resistance. So the hepatic fat goes high, increases, and that brings about insulin resistance in the liver, and therefore that causes increased plasma glucose and increased basal secretion of insulin. The VLDL excess produced from the liver fat also goes to the islets of pancreas, produces the lipotoxicity in the islets, and that again produces decreased insulin response to the food. And that's how this twin cycle between the pancreas and the liver is responsible for this kind of a diabetes hypothesis. A meta-analysis of 16 patients estimate that the effect of NAFLD on the risk of independent incident diabetes stratified by length of follow-up of 5 years, published in Diabetes Care, that NAFLD is 200-fold responsible for diabetes, which again a cardiovascular disease, and the steatoid itself has a 64% increased risk of a cardiovascular disease. And what is interesting, that you can get cardiovascular disease only at the patient, when patient has NAFLD. So NAFLD is a CV risk problem. So there's a 64% increased CV risk. There's also risk of hepatitis C virus and of course hepatitis D compensation. So 2020, NASH is expected to be the first cause for liver transplantation. So therefore 12th June is observed as the World NAFLD Day. And that's how you take care of the liver so that you don't get NAFLD. With that, thank you very much.